right, let's see if we can get started on time and try to maintain our timing for the day. Welcome to day 2 here on CVI. We are here for the challenging case competition. I am Lawrence Garcia out of New York City now. We have a really good panel, including Dr. Narayan, Bailey Estes, Rafi Feroz, also last year's winner. I was told not to bring that up, but I'm going to bring it up anyhow. Congratulations. Dr. Lee, Dr. Sanfo, Dr. Sai, and Dr. Varghese. We have a series of 9 presentations, all of which will be 10. I'm joined here by my co-moderator as well. Thank you. You have 10 minutes. We're going to grade you on content, deliverability, and if it's relevant. So we're going to group huddle. We don't have a scoring system that's electronic, so we're going to do the old-fashioned way. And we're going to pick the top 2, so a winner and a runner-up, which will then go up against each other tomorrow. So welcome. I look forward to all these presentations. They look fantastic. So why don't we start? We have the first 3 for any new presenter. I think Dr. Farizi, Dr. Lutz, and Dr. Goal. We don't have your presentations. If you're going to present, you need to meet Josh in the back to get your presentations to us. So if we can start with Dr. Ashraf, who will be discussing ascending aortic aneurysm treated with a conformable thoracic stent graft. Dr. Ashraf. Can we get his slides up?
All right, perfect. All right, thank you, everyone. Thank you, moderators. We'll get started. So we're talking about ascending aortic aneurysm treated with a thoracic stent graft. So starting off with the history, we had a 67-year-old gentleman who was status post CABG with a surgical AVR the year prior, who was found to have recurrent ischemic strokes. He also had a history of paroxysmal AFib and hypertension. As part of his workup, he was noted to have this ascending aortic aneurysm, and so further dedicated studies were done. And so with the CT chest, we found to have this circular aneurysm. Just some relevant distances that were measured. This aneurysm was in the ascending aorta. The total distance from the root to the brachiocephalic was just 103 millimeters, so just about 10 centimeters. Regarding his grafts, he had a patent lima to LAD, but notably his vein grafts were down. So we were presented with this clinical challenge. How do we do managing of this ascending aortic circular aneurysm endovascularly? The reason for endovascular was, one, it was a recent surgery, and a redo sternotomy was less desired, and the patient himself was pretty adamant. Actually, he refused any sort of surgical intervention. And so the way this procedure was done is essentially what we did was very similar to how a TAVR procedure would be done transfemorally. We got access right and left common femoral arteries in the standard fashion 6-French sheaths, and then pre-close the right arteriotomy, and then on the right common femoral vein, a pacing wire was advanced to the right ventricle. Through the left femoral artery sheath, a marker pigtail was introduced to the thoracic aorta, and on the right common femoral artery, a 24 French Gore sheath was inserted. Aortic angiography was done to locate the precise location of the coronary arteries and visualize the nominate artery as well. The working view was an LAO 35-degree view. And then a Lunderkist double J was advanced into the left ventricle. Now a Gore conformable thoracic stent graft. This was a 45 millimeter by 10 centimeter graft. This was advanced into the ascending aorta. The patient underwent rapid pacing, and the stent graft was deployed. The marker pigtail was repositioned into the true lumen of the aorta, and angiograms were obtained. Final aortogram was obtained that demonstrated no damage to the aortic root, patent native osteotomy of the coronary arteries, well-placed stent graft just proximal to the nominate artery with exclusion of the aneurysm. So in this case, we present the novel use of a conformable thoracic aortic covered stent graft in the ascending aorta for an iatrogenic, non-mycotic circular aneurysm. Endovascular options for ascending aortic aneurysms are an area of ongoing feasibility. Optimal outcomes do require careful anatomical considerations. In our case, the distance between our patient's coronary ostia and the innominate artery was greater than 10 centimeters, and his existing vein grafts were no longer patent, which both were key in allowing us to use this specific thoracic graft in the ascending position. We found that the procedural aspects of deploying the stent graft were very similar to deploying a supraannular self-expanding aortic valve. Alternative options to treat this specific pathology could have included coil embolization to isolate the aneurysm. A few things to note: there is no current approved device for the ascending aortic position. This is something that's being actively studied right now in the surgical world, primarily for treating dissections, as those have a very high morbidity and mortality and is an area of interest for non-surgical options. There's a few challenges that the ascending aorta presents, which is why they have grafts for the descending but not the ascending aorta. The shape of it with the inner and outer curvature makes it a little bit more challenging. The physiology of the ascending aorta is very interesting. It expands with systole, and it has a certain amount of compliance that is part of how our cardiovascular system essentially functions, with storing some of the kinetic energy and potential energy, giving us a Windkessel effect. And so some of these things are why there isn't, I guess, the same amount of options available already as there are for the descending aorta. It's a harder part of the aorta to work with. But in our case, it was kind of the only option that we were left with, and we were able to successfully place. Long-term effects, though, this will affect the hemodynamics as far as how much, in the immediate setting, there wasn't really an appreciable difference, but just something to keep in mind. All
right. A great presentation. This paper is open for panel discussion. Anybody have any questions?
Like 10 seconds? Oh, I have to, okay. Just that kind of morning. I know. I already locked myself out of my room twice today. So can you talk a little bit about how you picked the Gore graft? Because there are other thoracic aortic grafts out there. And I think you were very lucky you had the 10 centimeters, because oftentimes the length is the issue. Because you need,
very much.
So, but were there other characteristics of the different types of grafts that made you think that the Gore graft would be the one to use here?
For sure. So Dr. Dharmaraj, my attending, who did this, is very familiar with the Gore products. And so this specific graft, I think, had the most conformability, which allowed it to be bent into the best shape for the ascending position. As far as the sizing, I think 10 centimeters tends to be the more standard size for the thoracic grafts. I don't believe there's a shorter option. That's part of why I think this has been an issue with using off-label thoracic grafts. I know there have been reports of using abdominal aortic aneurysm cuffs, which are shorter, but those tend to require multiple and sometimes overlapping when you're placing them, and those have had issues with endovascular leaks in the literature that I was finding. As far as the width, this is something that it tends to be an important factor. It's something that needs to be oversized for the ascending position. And so in the literature, most operators try to oversize from 10 to 30% because of the way the aorta expands during systole. So that's how we ended up with the sizing we chose, 10 by 45.
Yeah, I don't think you're going to get bigger than 45. 45 is like the biggest it will come. But the other thing I think is, like, some of these grafts have the bare metal at the top. So you probably don't want the bare, even this has a little bit of bare metal at the top, right? This is the tag, the Gore tag graft. There's a little bit, but others have more bare metal. So you don't want to have the bare metal like going into close to the valve, right? But then my other question is, do you balloon this? I would think not, but.
It wasn't ballooned. After deployment, no.
So can I ask, what was the time frame between CABG and this?
About just over a year.
So is this truly a saccular aneurysm, or is it a pseudoaneurysm?
It was thought to be a saccular aneurysm.
Because it looks like a pseudoaneurysm to me.
Like, do you think it might be a clamp injury or something related to the CABG?
That was a theory.
Almost always it's the anastomosis of one of the grafts fails. and you bleed into a pseudoaneurysm. We've done a couple of these when I was in Boston, and we always use like an occluder, and you guys thought about that. It's smaller, it works because it doesn't really have to be in zone 0 for so long, for a length. Given that your vein grafts were occluded, either way it works.
Right, that was a big part of exactly why it worked.
Because I presume that if it was a year ago, they had the CABG, they had a CT scan before, and it wasn't there.
No.
So it has to be a pseudoaneurysm, right? Okay. Any other questions?
Very nice presentation, Dr. Ashraf. So you brought up coil embolization, which is very interesting, and there's a couple of case reports on coil embolization and this kind of saccular aneurysm. Can you talk a little bit about in what circumstances someone may choose coil embolization versus placing a graft? Like, is it dictated by the size of the aneurysm or some other factor?
It's a great question. I don't have the perfect information to give back to you, but I think part of that procedure planning comes into the size of the neck and how large that is. I think the smaller the neck, the more success you'll find with coil embolization. And then also in our case, if we had patent vein grafts and such to preserve them, we wouldn't be able to use a whole thoracic stent graft.
Can you comment about the images that you need before perform a procedure like this? Specific images. What did you guys perform? And was it a one surgeon decision, or did you guys have a committee to go through over this? Because this is not a day-to-day kind of procedure.
No, very much not. It was primarily driven with CT imaging, and then this was discussed between cardiology and vascular surgery. I know that in literature there's documentations where they've used transesophageal as well as intravascular echocardiography, but in our case we saw that it was able to be done with just CT imaging. And then angiography, just pre-procedure.
Yeah, I think a 4D CT is very important in those cases if you have that availability. And I think a case like this, it should not be a one department because you may not have the graft, or you may have to go to a coil with kind of different ways to do it.
For sure. Yeah.
How do you guys plan to monitor it long term?
It's a great question. I think because the way the pre-procedure imaging was almost CT, it should be long-term CT. Based monitoring.
How frequently?
I don't know the perfect answer. I think 1 to 2 years, ideally, I'd imagine would be the best way to move forward.
Well, thank you so much.
Thank you all.
So our next speaker is Dr. Luay Alalawi. If you can come to the stage. If you don't mind, you guys can, when you first start presentation, just introduce yourself, where you're from, and what level of training you're in.
Good morning, everybody. My name is Dr. Luay Alalawi. I'm a third-year cardiology fellow at Corpus Christi Medical Center. I would like to thank the directors for this conference and the moderators and the panelists for giving me the chance to present my case. It's about a massive PE and what do we do? I have no disclosures, unfortunately. So the case is about a 50-year-old male with history of uncontrolled diabetes, complicated by left toe gangrene and abscess. Initially, he presented to the hospital for incision and drainage for the abscess. On the third day of post-op, he was being set up for discharge. He suffered from PA arrest. So initially, CPR lasted about 7 minutes. He responded to defibrillation. Unfortunately, 2 minutes after that, he continued to become hypertensive again and went into VFib-VT. So at that point, due to multiple cardiac arrest, the shock team was activated and VA ECMO or eCPR was initiated. On 4:35 in the morning, he was successfully cannulated with a 25 French venous drain and a 15 French arterial return and a 7 French perfusion catheter. The total time for the CPR, eCPR lasted about 36 minutes. So at that time, the patient was hemodynamically stabilized, temporized, intubated. Now we have time to think what happened. So his diagnostic workup included left heart cath, CT, echo, and blood work. And the CT showed This is the axial images, as you can see here, showed a very large saddle embolism into both right main PAs as well as interlobar and lobar arteries, and CT evidence of RV strain. And here we can see the same thing on the coronal images. Large thrombus burden, as you can see in these pictures. Echo, as we all know, is going to show flattening of the septum, dilated RV, dysfunctional RV, and McConnell sign. So what do we do next? Now we have a patient that have multiple cardiac arrest and on VA ECMO, stable for now, on inotropes, vasopressors. What do we do? Do we refer him for percutaneous mechanical thrombectomy? Do we administer thrombolytics? Do we refer him for catheter-directed thrombolysis? Or do we just continue on the VA ECMO support and full-dose heparin until he improves? Question for the panelists. Any ideas, any opinions?
Well, you had ongoing CPR, so it's probably one of the biggest absolute contraindications for lytics, systemic and intra-arterial. I think you're relegated to trying to grab and pull.
Yep.
But
Yep.
I'll leave it up to you as to what you did.
Yeah, that's exactly what we did. We took him to the cath lab and we performed percutaneous mechanical thrombectomy. So, and these are the pictures. Basically, we placed 20 French large bore aspiration thrombectomy catheters in both the right and left main PAs, and you can see here in the pulmonary angiogram large thrombus burden in the right main PA as well as the left main PA. And some distal clots as well that eventually related to his obstructive shock. So after grabbing and pulling, aspiration pulls about 3 to 4 times each main PA. We ended up with this result, patent. We sucked out the majority of the clot burden. As you can see, the distal lobar arteries, there is some filling defect there, but the patient did well. So what was the hemodynamics before and after, which is a very interesting thing to look at. The PA pressure prior to thrombectomy showed a 31/14/20, which what would you expect in acute RV failure? His mixed venous O2 was 55%, which what would you expect in cardiogenic shock? And the echo markers or the echo numbers, dilated RV 50 millimeter, dysfunctional FAC of 12. Post-thrombectomy, which was done about 6 to 8 hours after the procedure, much, much better numbers. And the BA pressures actually were done right after the aspiration thrombectomy, before patient going back to the CCU, and normalizing the PA pressure and normalizing the SVO2, concluding the resolution of his obstructive shock. So what happened, as I mentioned before, vasopressors and inotropes were de-escalated in the cath lab. The patient was extubated, VA ECMO was decannulated within 24 hours, and he was discharged from the hospital within 2 days or 48 hours after his cardiac arrest. So, and we repeated the echo just prior to discharge, showed pretty much normal echo. So what is the key learning factors here? What do we learn from this? Number one, we can use VA ECMO more. We should use more VA ECMO frequently in patients in obstructive shock and massive PE. And in this case, it seemed to improve morbidity and mortality for this patient. And it also can be a bridge for a more advanced or reperfusion therapies such as large bore aspiration thrombectomy, which will help debulk the thrombus burden and relieve the shock state. And most importantly is to have the protocol set up for timely and prompt response, which is a key factor for success in patient with obstructive shock. And the last point is never underestimate your left toe, because he came in with left toe abscess and he ended up with multiple cardiac arrest. Thank you very much. I would like to thank my mentors, Dr. Conformable and Dr. Thomas Alexander, for guiding me through this case. Appreciate it.
Yeah, excellent case. And this is so. How many ECMO do you guys do a year? Do you have a number?
So that case was done at Methodist San Antonio. We go there for our heart failure rotation, and they're a major transplant center. They do a lot of VA ECMO. I don't have the number on top of my head, but I'm helping Dr. Conformable starting a registry, because he does a lot of VA ECMO bridge to aspiration thrombectomy, and for the past, I believe, 2 years, we've collected 26 patients.
So, question for you. This is the patient is lucky that he coded during the day. If the patient,
He coded at 4:35 in the morning. Yeah, yeah. So that's part of like another victory for the team, that they were able to set up or activate the shock team so fast, and they were able to cannulate him, and the total CPR time was 35 minutes.
And they cannulated him at the bedside?
At the bedside, yes, sir.
what access did you guys use?
It was groin. Femoral.
And any of the panelists has questions?
I have a couple of questions, actually. The echocardiogram actually shows still pretty profound RV dysfunction, and that was on the VA ECMO already.
Yeah.
It's interesting because most of the time when you actually do full unloading with VA ECMO, actually the RV completely normalizes. And in fact, VA ECMO is a way that you can treat massive or high-risk PE. Essentially just give the patient some time for the heparin to work on VA ECMO. Second question, I noticed during the angiogram, there's actually a balloon pump in the screen as well.
Yeah, so that's part of the, I mean, that's a whole nother discussion. It's part of the shock team protocol for venting associated with ECMO. So all the ECMO patients, they do LV vent either with Impella or balloon pump.
Okay, so interestingly enough, so with VA ECMO, you're essentially, think of it dumping all of the blood back into the arterial system, right? So true venting of the LV is actually doing Impella. Balloon pump actually pushes, right? Pushes backwards as well, so you're actually slightly increasing some afterload too. So it's an interesting mix of mechanical support.
I think I might be, my mind could be kind of skipping a little bit here, but I believe there is a Japanese study that was done, was published a year ago or so, was specifically done on LV venting with VA ECMO, and they did include patients with Impella as well as the balloon pump.
One quick question. Great presentation.
Thank you.
So you had bilateral venous access groins, right? And when you were aspirating, you start to be careful with the ECMO circuit when you have, because you're basically just going through the same axis and trying to aspirate. Anything that's hanging onto the catheter, you're trying to just flush and bring it back, it's going to be a problem. Was there any issue dealing with that at all when you guys performing aspiration? Because anytime it gets into the circuit, it's going to be a problem.
Yeah, absolutely. That's a great question. So it's part of the challenge here. Every time we performed a aspiration suction, the venous catheter was clamped. That way, we make sure that nothing, no air or nothing goes into the drain.
I have a question. Great case and great teamwork. I work in a facility, we don't have ECMO. So what are the circumstances would you choose an RV Impella or VA ECMO? Do you have both to your facility?
Yes, we do have both. I think in this patient, just because he have obstructive shock and he have recurrent cardiogenic shock, the choice, because if you put RV Impella, the blood is not going to go past the PA anyways. So in that case, VA ECMO is the optimal choice.
It's the only one that unloads and gets your oxygen. It bypasses the lungs entirely. As a teaching point, that's a fantastic presentation. We got to move on. But if you look at the angios, that 26 French tube, I highly recommend every fellow and every operator to ever work in the pulmonary circulation. Go to the OR and watch a CABG, and you'll see how thin the PA is. And if you see your PA catheter, it's tenting that PA. And how we get away with what we do in the pulmonary circulation is amazing. All you need is one bad complication. You'll remember it because I had one happen. But that's paper thin in there. So just be aware where that catheter is as you inject. It's one way to get use a pigtail, but you know, these 26 French holes are huge, so fantastic. Thank you.
Thank you very
Great
much.
presentation. Next up is I'm going to destroy the last name. Gajanana. Nana. Thank you. I'm sorry. I'm Garcia. That's my limit. Yeah, I saw that. So you're going to be chatting about embracing the unpredictable management of iatrogenic popliteal artery aneurysm with endovascular approach.
Good morning, everybody. My name is Deepakraj Gajanana. I'm one of the interventional cardiology faculty at Cleveland Clinic Akron General Facility. We'll be talking about management of iatrogenic popliteal artery aneurysm. Next slide, please. So
You got a clicker here.
Oh, perfect.
Big green.
Okay. All right, no disclosures. This is a story of a 90-year-old female with risk factors for peripheral arterial disease. Did have mild PAD in the past, now complains of claudication upon walking 100 steps. So these were the imaging and diagnostic studies. Normal ABI on the right side, and on the left side, her left toe brachial index was 0.45. She did have arterial ultrasound bilaterally. It did demonstrate probable short segment occlusion versus heavily calcified segment in the popliteal artery in the proximal segment, especially on the left side. And in the mid left popliteal artery, there was 50 to 99% stenosis. So, all right, so I will just highlight the steps and we'll show the images subsequently. So we brought her to the cath lab. So this is a lady with worsening claudication and has a severely reduced ABI and does have evidence of popliteal artery stenosis. So we brought her to the cath lab and we did abdominal aorta angiography. We did selective left lower extremity angiography. We modified the lesion and subsequently treated it definitively with PTCA with a drug-coated balloon. So these are the images. So we used a 7 French sheath up and over, and we did a selective angiography of left lower extremity. All right. So as you can see, there is a probable subtotal occlusion in the popliteal artery, and the left TP trunk had moderate stenosis, and there was a critical stenosis affecting the anterior tibial. So we were able to cross this lesion with a V18 wire, and we were successful in getting the TACRU 3.5 by 15 NC balloon. And on the right side, you see the scouting balloon that we were able to expand. I don't know if you can appreciate, there is severe eccentric calcification. At this point, we did IVUS that demonstrated nodular calcification in the popliteal artery. At that point, we were contemplating, should we just go with the shockwave balloon? Should we try to debulk it better? It was mostly nodular calcification, so we were a little bit hesitant to use any other device. So at that point, we decided we'll just give it a try with directional atherectomy. So we used a HawkOne LS directional atherectomy system. We did few passes, and then after that, we did the IVUS that demonstrated some break in the calcification. It was not completely expanded. At that point, we decided to use a shockwave balloon just to see if it would modify the lesion better. So we used a 7 by 50 millimeter shockwave, and then once we did the shockwave, there was better lesion modification. It expanded well, and then we did a definitive treatment with the 7 by 80 millimeter drug-coated balloon. So this is the final angiography. As you can see on the left side, the lesion is very well modified. It's open now, good flow, but then you do see some bulging in the popliteal artery. So we were a little bit worried. There was no dissection on the IVUS, and this was the runoff. At that point, we felt comfortable. Since there was no dissection and no distal embolization, we decided to finish the case, and then we discharged her on dual antiplatelet therapy for a month, and then we saw her in the clinic. So she was doing fine for a month or two, and then after 3 months, she started having recurrent left calf pain. And then she was seen by the vascular surgeon locally. And then the physical exam was unremarkable. She underwent lower extremity ultrasound, and then that prompted a CTA of lower extremity with runoff. So this was the lower extremity ultrasound that demonstrates a pseudoaneurysm arising from the proximal popliteal artery, measuring about 3.2 by 3.1 by 1.9 centimeter. And then since it was a pseudoaneurysm, they wanted to make sure there was no other aneurysm elsewhere in the system. So she underwent CTA of abdomen and pelvis that showed saccular aneurysm arising at the P2 segment of the popliteal artery. So at this point, so you have a 90-year-old female who did have claudication, who was treated with atherectomy device successfully, and then now she comes in with recurrent symptoms and what looks like iatrogenic popliteal artery aneurysm. So at this point, we decided to bring her back to the lab, and these were the steps. So again, we gained access in the right common femoral artery up and over with the 7 French sheath, selective angiography, and then we tried to stent it with one stent, but then it was not successful, so we had to use 2 overlapping stents. So this is how the angiography looked. So it shows an aneurysm in the popliteal artery with the good distal vessel runoff. So initially we thought we'll just stent it across, and we used a 7x50 wire band. And I don't know if you can appreciate, despite stenting and then ballooning, there was still a residual leak into the pseudoaneurysm sac that you can see on the right side. At this point, we thought probably it is arising from the proximal edge, and we decided to treat it with the overlapping stent. We used a 7x100 millimeter wire band stent. And then once we had this overlapping stent, and once we ballooned it with 7x60 millimeter NC balloon, there was no residual leak. And this is how the angiography looked at the end. So the teaching points in this particular case is popliteal artery aneurysm is often associated with abdominal aortic aneurysm. Now this is not iatrogenic, but iatrogenic aneurysm have been reported following use of atherectomy devices. In this case, looking back, probably the use of HOC1 was not a great idea. Now, even if they do end up with popliteal artery aneurysm, they can be treated conservatively. However, once the size goes beyond 2 centimeter, that's when the chance of complications or distal embolization go up. Now, if the patient is symptomatic despite lower size, or if the size exceeds 2 centimeter, that would become an indication for further treatment. The preferred modality should be endovascular, and surgical ligation or repair should be reserved for failed cases. So with this, I conclude my presentation. Thank you.
That was a good presentation, great case. Brings up a lot of questions. Any questions from the panel?
Yeah, I have a couple of questions. One, to the vascular surgeons also, is endovascular should be the first option for popliteal aneurysm? That is one question. Second question is, how would you do this case if you are treating this patient today?
So the answer to the first question, so we did involve the vascular surgeon the second time, and it was a collaborative given her age and risk factors, we decided we'll go endovascular. That was the answer to your first question. Now, the answer to the second question, looking back, as I said, after we used the Tacharoo balloon, after we used the angiosculpt, once we saw significant nodular calcification, probably it was not a great idea to use the atherectomy device. That is one thing that I would avoid. I know with the directional atherectomy, you can direct it to kind of shave off either the atheromatous plaque, but then sometimes you may not. Given the nature of calcification, it may shave off the media, and I think probably that's what may have happened. So I would probably avoid atherectomy if there is nodular calcification, and just stick with maybe a shockwave balloon, though it was not circumferential calcification. The other thing is, after use of angiosculpt, there was good flow probably we could have just used a drug-coated balloon and just call it a day. Sometimes we try to go for perfection, and then that's what happens.
Can you talk about how you guys chose to use the Hawk LS versus an M or a smaller device?
You know, the size of the cutter is still 0.3, 0.2 millimeters, so it's really not much of a difference. It's the primary jog which gets you there, but I think at the end of the day, we had 3 modalities, right? I mean, so you went sculpt, which I think I was working with Gary Gershoni, who started the damn company probably 20 years ago, and you know, that device works really well to score atheroma. It's awful when it comes to this kind of exophytic calcium, so I'm not sure that that's useful. And then the Hawk, I think, is directional, and that's the beauty of it. And you basically shave away the mountain, but you have to be dogmatic as to where that cutter is cutting. Yeah. To your point, the minute you get off the mountain, you cut into the non-diseased arteries when you get the deep cuts. And what you're seeing is the confluence of positive remodeling of DCB to the adventitial staining now of the DCB. And so that's how you get the positive remodeling for the aneurysm. And then I guess the third one is shockwave. So if you had to do it again, would you dump on angiosculpt? And you said already that you probably don't want to use atherectomy, but does in pad 1, 2, and 3, the lithoplasty, IVL, really works well even in exophytic arteries. So it tends to crack to allow this kind of thing, and that might get you at least a bang for your buck to come back and fight another day. Is that your kind of MO if you saw this thing again as opposed to the other modalities?
True.
I have a quick comment. Maybe a couple questions. And if this were to be a younger patient, will that still be your approach, endovascular, considering all the geniculate branches and everything that come off of the popliteal? Would you still prefer endovascular approach greater than 2 as a first option for someone who's young and healthy and active?
Well, I think that would be in collaboration with vascular surgery. Now that the vascular surgeons were involved, I would still get their input, depending on what they prefer.
I just have 2 comments really quickly. One is actually true popliteal aneurysms are almost impossible in women. Like the popliteal aneurysms that are associated with aortic aneurysms, I was told they do not exist in women. It's actually a very, very tiny number. You have to look in like a huge series, like population-based series, to find one. So this is like iatrogenic. It's just related to the procedure. But a true popliteal aneurysm is, you just almost never find it in women.
True.
If you find it something that feels like a popliteal aneurysm in a woman, you have to sort of look for other things because it's so rare. And the other thing to consider is like treatment of claudication that is popliteal disease in someone who's 90. You know, claudication is generally not limb threatening, and SFA iliac stuff, sure, but popliteal, I would consider that a little more carefully, especially if it's a non-limb threatening condition.
True.
Perfect. I think this is a very interesting case, but for the sake of time, we're going to move on. Thank you so much for the presentation.
Thank you.
Yeah, Dr. Farid, you ready? The presentation is ready? There we go. Let's do it. Dr. Franklin Farid, presenting successful open repair of a syphilitic thoracoabdominal aneurysm.
Good morning. Thanks to the panel for having me. My name is Franklin Farid. I'm one of the vascular surgery fellows at Baylor University Medical Center in Dallas and at the Heart Hospital Plano. So today I'm going to be presenting the case of a 40-year-old man who came to us with abdominal pain. He had a personal history of HIV, which at the time of presentation was poorly controlled, and 3 months prior to presenting to us, he was treated for latent syphilis after presenting with lesions on his palms and soles. During his workup for abdominal pain, he was found to have an aneurysm spanning from zones 4 to zones 9 of the aorta. And just briefly, for those who don't know about the zones of the aorta, zone 4 starts at 2 centimeters distal to the subclavian to T6, and zone 9 is below the renals to the bifurcation. He had no cardiac history, he had no hypertension, there was no personal or family history of connective tissue disease or aneurysm. and a smoking history of 3 to 4 cigarettes per day. Here you can see a 3D reconstruction of his CT scan. He's got a type 3 arch, and distal to the subclavian, you can see the aneurysmal change starting to take shape. His echocardiogram was demonstrative of essentially normal structure and function. There was no aortic root dilation or ascending aortic dilation. So he was surveilled, basically, because of his uncontrolled HIV. He followed with an infectious disease specialist, and after a period of 6 months of surveillance, he came back to us and was found to have an alarming rate of his expansion of his aneurysm by 12 millimeters. The HIV RNA was undetectable after that 6 months interval of heart therapy, and his RPR titer was 1 to 2. And in general surgery training, we don't really treat syphilis, or at least I didn't where I trained. And so I had to learn that this is called a serofast reaction, and those with HIV can remain serofast or seropositive seemingly for syphilis. So in the context of having a recent treatment for syphilis, an RPR titer of 1 to 2 was considered successful treatment. So he underwent a thoracoabdominal repair under left heart bypass with separate bypasses to the celiac, the SMA, the right renal, and the left renal. And you can see the right renal branch is a little bit hard to tell. It comes off of the very posterior aspect and goes around. His perioperative course was relatively uneventful for thoracoabdominal repair. He had a lumbar drain that was removed on postoperative day 2 after demonstrating normal neurologic function and motor strength. He had a transient AKA that resolved. There was no ileus to be heard of, and he was discharged in ambulatory condition on postoperative day 7. So really, really kind of a fairy tale story for one of the biggest operations we do in vascular surgery. And he was surveilled at 1 and 6 months as a standard for aorta. And as you can see on the reconstruction, he has a very, very good repair and is in very good health. So typically we think of cardiovascular syphilis as affecting the root in the ascending aorta because of the vasa viscorum. So this is a pretty atypical presentation in the context of no other reason for an aneurysm. There are some case studies and observational data of the synergistic effects of HIV and syphilis on cardiovascular syphilis. So the learning points, I think, for this case are recognizing those synergistic effects. After syphilis reached a nadir in prevalence in early 2000s, it's on the rise again. And this time, in this era of syphilis, we have HIV. So it's important to be cognizant of the rising prevalence of cardiovascular syphilis, and also to be able to anticipate atypical presentations of cardiovascular syphilis.
We'll start with the panelists. Any questions?
Sure. Very interesting case. How do you, so for mycotic aneurysms, we'll treat them with antibiotics and then put them on, 6 weeks at least of IV antibiotics and then indefinite suppression. What do you do with the syphilis patients?
So he was not suppressed with any antibiotics for syphilis. He was on Bactrim for prophylaxis for his HIV, but he was treated with 3 rounds of penicillin. I think the 2 million units IM weekly for 3 weeks. But there was no suppressive antibiotics regimen for his syphilis, and this was based on his infectious disease specialist.
So then, do you do anything else to the graft? So oftentimes we'll soak them in rifampin and,
yes, his was soaked in rifampin. Yep.
And was there consideration for other conduits? I mean, we would never use deep vein in this position. That just leads to a disaster. But some people will use cryo, like cryopreserved aorta, for example, as opposed to the rifampin soaked Dacron.
I'm not actually sure if there was any consideration for anything other than rifampin-soaked Dacron.
It is hard to put the branches onto the cryo. Then you're like sewing extra branches onto that, so it's like not really practical. And I think most people would just use rifampin-soaked Dacron anyway. But it is interesting because usually you would see this for like bacterial, like mycotic bacterial infections, like not so much for syphilis. So.
Sure.
So if this patient is not a surgical candidate, is there any literature showing like endovascular therapy for this, or would you just tell the patient they're out of luck?
Well, there are kind of there's increasing evidence that endovascular repair for mycotic aneurysms can be safe. I think the general idea is that you want to make sure that the infection is treated first. But there have been case reports of, there was a hybrid repair, I think that was reported in 2003, but this was also an ascending repair. So the patient had a sternotomy with repair of an ascending aneurysm, and then a distal repair later with a TAVR. So there are reports, yes.
Very unique. Yeah, given that syphilis is not very common, when you discover aortitis from syphilis, whether it's in the root or the rest of the aorta, do most of those patients require mechanical intervention, or is there the opportunity to manage them medically?
From my understanding, in the ascending aorta and the root, this is more in the purview of cardiothoracic surgery, but I think it's treated the same as any other ascending aortic aneurysm, in the sense that there's no special consideration like you would have for a bicuspid valve or connective tissue disease. So it's just treated as a regular aneurysm.
Any specific survey or medical therapy or anticoagulation this patient will require, different than a traditional patient?
I don't think so. Just from what I understand, yearly scans and no suppressive antibiotics or special antithrombotic or anticoagulation.
So is his syphilis being treated?
His syphilis is being surveilled, and it's being surveilled by the titer. And from my understanding, if the titer increases by a factor of 4, then you would have either a reinfection or recrudescence of the infection.
Is there a downside to treating the syphilis with a plastic in his aorta?
With suppression? I'm not sure. I think this is...
I'd ask the ID guy, because, the downside is now you have to explant the entirety of his thoracoabdominal stuff.
Mm-hmm.
It may not be, I know drug resistance is a problem, but Jesus, why not treat it?
Yeah, I actually don't know what the answer is for syphilis, because like for the mycotic stuff, we just put them on antibiotics indefinitely.
That's the problem with those doctors. You don't know the ID part of it.
But the thing is, like, the stakes are high, right?
Yes.
You have a piece of Dacron in a very tricky spot. You're never going to explant this again.
Correct.
So that's why we're just like, just put them on antibiotics, because you don't want to deal. But the other thing is, like, I actually don't know the question to this either. Like, do you put stuff around the graft? Like in the abdomen, we'll put omentum around it. You like wrap omentum, but like some people will take like an intercostal pedicle or something in the chest. Like, what do you put up there between the graft and the sac that presumably you didn't get out because it's like so hard to get the whole sac out?
Right. Yeah, and part of the aortic wall was resected even to send to pathology, which ended up not being very fruitful as far as the pathology report. But even closing the sac around the graft was harder than usual because we had resected part of the aorta. So
this was my case. I'll highlight a couple of points. Number one, we get a wide debridement of the aortic wall, almost in its entirety. So it was completely resected, sent for pathology, and interestingly enough, grew nothing. The only pathological finding that was even remotely consistent with syphilis were some cells that were identified. But other than that, it was essentially a normal pathological aorta. We talked about potentially doing an omental flap on top of the graft itself. However, this was a completely retroperitoneal exposure. We felt like there was not a lot of benefit to opening up the peritoneal sac and then transposing some of that omentum down on top. And then otherwise, soaking the graft in an antibiotic or rifampin is what we chose to do.
thanks, Dr.
Very
Forte.
interesting. Sometimes when it doesn't grow out on the culture, I actually send it for staining, like actually pathology to like stain, like do silver stain for organisms, because not everything will grow out on the culture.
That's a great case. I'm still, I mean, in my training, I saw some syphilis, and to have it come back is like a bad nightmare. I hated it, and it was awful. Thank you.
Thank you very much.
Dr. Farid. Is Katherine Lutz here? Dr. Lutz will be doing a left subclavian dissection discussion after transfemoral TAVR with prior CABG. Dr. Lutz.
Excellent. Thank you so much for having me. My name is Katie. I'm one of the general third-year cardiology fellows at OHSU. Okay. Ooh. Looks like it advanced to the end. Oh, I see. Okay, thank you. Okay, so our case is a 76-year-old female who presents for a planned TAVR for symptomatic severe aortic stenosis with a plan to undergo a 26-millimeter core valve Evolut Pro Plus. Pertinent cardiovascular history, the main thing to note is that she had a bypass in 2018 with a lima to LAD and then 2 vein grafts. And her aortic stenosis is from bicuspid aortic stenosis. This is her pre-TAVR CT. So the plan was to go transfemoral. There was some calcification in the femoral arteries, but not too much. Notably on the aortic arch, she had quite a fair amount of calcium and a little bit of narrowing, but otherwise it looked pretty straightforward for our TAVR case. Here's just an aortic root shot prior to placing the valve for alignment. And then we pass the sheath through the valve here and deployed the valve with an aortic root shot. There was a little bit of AI that went away after we ballooned it open here. Overall, we thought the procedure went really well. There was a little bit of resistance after passing the aortic arch, but otherwise it seemed like a pretty straightforward TAVR case for us. In the PCU, we got paged that she was complaining of some left hand numbness, and she ended up having some non-Dopplerable radial and ulnar pulses afterwards. Bilateral lower extremities were normal, and prior to the procedure, her radial pulses were fine. We sent her emergently to a CT scan and found that she had a dissection of the subclavian there. You can see it with the red arrows, and as well as acute occlusion, which was proximal to the lima graft. So our challenge was, how do we manage this subclavian dissection in the presence of a prior bypass patient? So we took her back to the hybrid OR. We had to get vascular surgery involved because we don't do peripheral interventions at our institution as interventionalists. We went right femoral. We got right femoral access, as well as cut down the brachial artery prior to this aortogram. You can see here, this is pointing to the subclavian dissection. So we advanced a glide wire past the subclavian dissection there and had a fairly significant tortuosity and a little bit of difficulty delivering equipment. At this point, we ended up placing a sheath in the brachial artery. And to help us with advancing the wire, we used a gooseneck snare to kind of make a little bit more of a rail, as well as to confirm that we were intraluminal, which we were with this. We dilated the area of dissection here and here. And notably, we wanted to be very careful of where we placed our stent. So the dissection there was proximal, luckily, to the lima to LAD and is patent here. The lima is outlined by the red arrows, and you can see the course traveling down. So our plan was to place the stent just proximal to that and cover the area of dissection flat. So we used a 14 by 40 millimeter stent, and with the blue arrow shows the edge of the stent, and it's a little bit difficult to see, but the red arrows are showing that it's proximally placed to the lima graft there. We post-dilated the stent here, and then we had really good, excellent flow here following stent placement as well. Here's our left upper extremity aortogram. She had Dopplerable pulses at this point, and you can see that there's pretty good flow down the brachial and axillary arteries as well as down to the radial. So resolution of our challenge, she ended up having complete resolution of symptoms after she woke up from general anesthesia. She started on some antiplatelet therapy and then discharged home. Key learnings for us, so it's pretty rare to have a subclavian dissection, especially when using transfemoral access. And we saw on the CT scan that there wasn't really that much calcification. But we promptly recognized it and sent her to CT scan and brought her back to the lab almost immediately. We used a snare in this case to try to advance the wire in the setting of severe tortuosity, as well as it helped us to confirm that we were intraluminal. And finally, care must be taken if there is a presence of lima in a subclavian dissection. Thank you.
This paper is open if anybody has any questions.
I have a quick question. What type of stent did you end up using? Is it an open stud stent, or is it a covered stent, or is it a balloon expandable or self-expanding?
Yeah, it was a Viabond stent, so it was open strutted stent. Yeah.
Were you worried about covering the vertebral, or not really?
I don't think so. It's a good question. No, we weren't worried about that, and there was good flow upwards that way too.
Because that stent really covers vertebral for sure.
Yeah.
Because it's around the bend, and vertebral you can see it just in the first picture and you can't see in the second picture. Hopefully she didn't have any acute symptoms and she had collateral circulation from the other side. But it's very uncommon. What do you think the reason for the subclavian dissection is? I mean, it's not from the aorta. It just randomly is a subclavian dissection.
Yeah.
Think it's just something was pushed against it with the angle?
My guess is that since there was a little bit of stenosis is traveling up there, and then a little bit of difficulty with advancing some of our equipment, that potentially some of it maybe got with pushing and pulling got knocked up and dissected it up there. I'm not really entirely sure of the mechanism though.
I mean, one last point is just the retrograde snare was a really good idea, but wiring retrograde will be actually favorable in this case because the dissection is antegrade. So you have higher chance of straying true lumen and pass the wire, and then use this to stent from the ostium. But it's a really good thing that you made sure that it was intraluminal before you stented.
Thank you.
Yeah, I guess my question is, Medtronic doesn't have steerability, right?
Right.
The core valve. So to me, it seems like it has to start in the aorta because you didn't instrument the arm, right?
Yeah, we did not.
We do all ours with radial pigtail. So it just seems odd that you would have this isolated subclavian, and there's this one angio, I think it's your catheter, but it almost looks like it starts in the aorta, and there's calcium there
Yeah.
to the level of the subclavian. But I guess my question is more technical. Why not just come from the wrist? Because you're going to be in a true lumen downstream.
You mean just go from brachial to...
Well, brachials, I hate brachials because then there's pseudoaneurysms and all this other crap that happens. But why not just do a radial and just come retrograde? It'll take a 7 French sheath, and you could put just a plain old balloon stent there, but it guarantees you're in the true lumen. Because I think you were lucky getting into the true lumen, not false lumen, because you don't know where you are when you get in there, and you still went retrograde to grab, right, with your snare, so
Yeah.
it kind of knows it. So it's just a technical question.
I think it's a really good point. I think that if this ever happens again, we hope not, that we can just go radial and deliver that way.
Did you have a follow-up CT to document your aorta?
Yeah, we did get a follow-up CT afterwards. I didn't include it in here, but the aorta looked fine afterwards.
It's a great case and a great save. I agree with all the sentiments that were previously expressed. I would also go retrograde from the arm as well. I think it's important to highlight intravascular ultrasound in cases like this so that you can identify the origin of the dissection. And essentially, you can figure out where your stent needs to be so as not to extend the stent that is too long and hence covering the vertebral artery or your lima.
Isn't that also, I'm sorry, isn't that also a very important point? I mean, the Viabond's a loosey-goosey stent, and so it's a kinked area, and so its likelihood of stenosis or shutdown is higher. And so that vert becomes kind of important, so I'm just not sure I like the Viabond approach here. I like an open cell design here.
Yeah, I mean, and also it's a 14-millimeter stent. It just to me, it's like oversized, especially small female. It was a female, right?
Was a female, yeah.
Yeah, 78-year-old. So I agree with everything. I think left radial, the only difficulty with the left radial, I do a lot of left radial, and I'm a big fan of left radial. I think this is a left radial case. The only issue you may have with is if the dissection really occluding the flow, the artery may be very small, so you have to depend on ultrasound, and you have to be very good at ultrasound. Brachial cut down, you're just adding now a surgical issue to a patient who just had a complication. So I think IVUS is absolutely important. I think you should not do this case without IVUS because you need to know where the dissections start, with the dissection end. Usually, if there's not a lot of tortuosity, this is a balloon mounted stent. You don't do self-expanding stent in that area. But again, I think there was maybe the consideration. There's a curve to it. Maybe they want to open cell. But again, you end up using a Viabond, so that's a covered cell. It's a covered. So I think it's an interesting case to not ignore what patients tell you. I think a lot of people have said, it's nothing, just ignore it. But I think it's important you guys did a CT. Nice work.
Yeah, thank you. Thank you.
All right, so next speaker, Dr. Oh man, I'm gonna butcher the name. Goal? All right. I said it correctly? Okay, you're next.
Good morning, everyone. My name is Mishita Goyal, and I'm a third-year cardiology fellow from Detroit Medical Center, Wayne State University, Michigan. So today I'll be presenting a case of removal of IVC filter, which was embedded in the cable wall. And I would like to acknowledge and thank our interventional fellows and Dr. Alreis for helping with the case. So next slide. Oh yeah, sorry. Okay. Thank you.
For everyone, you have a clicker when you're on the podium.
Thank you. It's not working. Okay. Yeah. So I have no relevant disclosures. So just a little background, as we know that the IVC filters are employed to safeguard against pulmonary embolism in patients with DVT who are unable to be on anticoagulation. And timely removal of these devices is crucial to prevent complications like infection, migration, and thrombosis. While conventional retrieval methods are usually adequate for the removal of IVC filters, in some cases, like the complications, like where the filter gets embedded in the wall, we need to get innovative with the removal of the device. So this is a case of a 65-year-old male with history of hemorrhagic stroke and DVT who had an IVC filter placed 3 months ago. And he presented for an elective removal of the procedure when he started tolerating the anticoagulations. So for the case, we accessed his right internal jugular vein. And initially, we used an 11 French retrieval system for the case. And as you can see here on the venogram, we saw that the IVC filter hook was tilted, and it looks like it's embedded in the wall, and you can see that there's like proximity to the left renal vein. So for those reasons, the clinical challenge that we faced was we attempted to snare the filter hook with ensnare and gooseneck multiple times, but all the attempts were unsuccessful. So at this time, because of the position of the IVC filter, we had few options to consider, the options being using forceps, which we were hesitant to use because of the proximity to the left renal vein. This filter was placed just like 3 months ago, so we did not think we would need laser, and it didn't look that endothelialized. The other options were inverting the filter. We chose to actually use a modified snare loop technique, which after the case on literature review, we found it's described in the literature, a modification of it as hangman technique. So after this, we upsized our sheath to 16 French for more equipment delivery. And using a straight tip glide wire and SOS catheter, we advanced the glide wire under the IVC filter neck, which is different, which was the modification instead of passing it under the filter struts. Then using the ensnare, we snared the tip of the wire and pulled it into the sheath and eventually externalized it. And then using the wire loop, we applied gentle tension on the wire while we advanced the sheath over the glide wire loop. So eventually, we were able to finally get the filter off of the wall and remove it. So the learning points from this case that despite the shorter dwell times, we can frequently encounter situations like this, and adequate preparation is necessary. And modifications in those cases could be used like using a larger sheath to allow passage of more equipments and catheters. And the other tools available to us, like forceps and lasers, and considering if those are appropriate for the situation. And the techniques that I found after literature review, there's like hangman technique, using the dual axis to pretty much floss it out, and like using the balloon for displacing the filter off of the wall. With increasing filter retrieval cases and more specialties performing it, there's like need to explore and compare these advanced techniques for certain indicated indication situations. And in conclusion, hangman retrieval technique, which was originally described in Journal of Vascular Surgery in 2015, but they used like a 14 French sheath, and we use a 16 French sheath. Those options are convenient and safe approaches for IVC filter removal in cases where the filter hook gets embedded in the cable wall. Thank you, everyone.
Any of the panelists? Comment, questions?
How old was this filter?
3 months.
I can start. I mean, first of all, thank you for taking that filter out. So I deal with a lot of, my oldest filter is 21-year-old, and I just hate doing them. But those patients are coming with filters that forgotten, and it's good for someone. I think a VQI from SVS has now when you place the filter, if you are part of the VQI, you have to take it out within a certain time, and they give you a reminder to take it out. It's important. What would happen? So first of all, you think it's embedded in the wall. Do you think you guys should have just stopped, get a CT scan, figure out what's going on there before you proceed with this?
That is actually something that I reviewed in literature as well, like using a CT scan for even like pre-preparation for elective cases like this. But in the literature, I did not find that it showed any benefit. But in this case, it looked like on the venography that we got that the struts were not embedded. It was just the hook that was embedded. And if in case our modified technique did not work out, probably that would have been the next step where if we had to like actually resort to other options like using forceps or laser, we probably would have aborted the case and had better planning and brought the patient back in again. But this case, like it looked like it was just a hook, so we gave it an attempt with like upsizing the sheath.
Any other panelists?
I think the important thing that you did was upsize the sheath, and that's a good point, to just give yourself more options. The easiest thing I do for these, which you alluded to, is getting femoral access and just putting a larger balloon. Often if you can just use a multi-purpose guide, wire up next to it and put a balloon, you can cant these so that they're more central. And then it's a cheap way without getting a CT scan to really see how that hook is going to behave. If you can get a balloon in and next to it and inflate the balloon in the tip centers in the IVC, you know it's not embedded. If not, then I'd more likely pause at that point in time and get further planning before I do something more aggressive.
Thank you for that point. When I read that, I found it pretty cool. I haven't watched that, like the balloon displacement technique as yet, but I would believe like that probably also would have been like the next step before, again, planning it further. But thank you.
What wire did you guys use?
Sorry, say that.
What wire did you guys use?
The glide wire.
Stiff, soft?
The stiff one.
But you externalize that, right?
Yes.
That's always hard for me to make that loop and make it retrograde.
I think this.
It's a tough.
Yeah, I think the sauce catheter that you use is the key. Just be careful. It's a short catheter. I think if you do that, again, you had the pictures very, very beautifully seen. You have the end snare, you have the sauce catheter, you have the glide wire. The only thing I would recommend is just be careful when you do this. Sometimes it's a two-person, and you just have to hold it very tight. And then your last video, you kind of jumped through it. You got to be careful with that, because when you pull back, your goal is to straighten that tip and you get it into the sheath. If you don't pay attention, you can kink it, break it, and now you have a broken filter in your hand. And now you have to get a forceps, and then that can dislodge the lung, become a whole mess.
Right. Thank you.
Next up is it Dr. Ruddy? She will be chatting about stage repair of a thoracic aneurysm complicated by dissection.
Green button, I can handle that. All right. Cool. All right. Hello, everyone. My name is Ann Kelly Rudy. I'm one of the now second-year fellows at Baylor University in Dallas. No disclosures. So my case presentation is a 76-year-old female who presented as a transferred from an outside hospital after a sternotomy, aortic valve replacement, and a debranching procedure to her innominate artery. Her preoperative anatomy showed that she had a bovine arch 7 days prior as part of a staged procedure for a thoracic aneurysm by another cardiothoracic surgeon. Her pertinent cardiovascular history was this known thoracic aneurysm, which she had been following. The maximum diameter was 5.6 centimeters, and there was no preoperative imaging or reports that indicated that there was any dissection related to it. She also had mild to moderate aortic regurgitation, which prompted this, with her size, is what prompted her repair. She arrived to our ICU, like I said, post-op day 7. Pretty deconditioned, mildly hypotensive in AFib with this CT scan. I hope it plays. Do I have to click again? Okay. So again, just to point out some concerning features on the CT scan is she did have this dissection, which again was not noted on any preoperative imaging report. So the concern that this was potentially iatrogenic. If you saw back, she did have a significant hemopericardium with a few air bubbles that were a little bit concerning for us. Fortunately, she presented with no emergent need for dissection repair and that she had no evidence of visceral or limb ischemia. So we did have the opportunity to kind of approach this in a multidisciplinary team approach to figure out how to best repair this. That's just the coronal view, and then we have a reconstructed image as well. So the clinical challenge, I think there's a couple here. One, this is a transfer and a post-op from another surgeon. So just one, gathering information, figuring exactly out what her preoperative indications were, her preoperative anatomy, and then what changed in the course of her operation. If we're thinking about doing this from an endovascular approach, it would be a zone 1 landing zone with quite an acute angle, which given my limited experience, but after patients have ascending repairs, I've noted that that Dacron can fold and make that angle a little bit difficult. She obviously had a very large aneurysm, including a dissection, and her dissection did extend to her common iliacs with multiple fenestrations. So the resolution of the challenge, I did kind of give an abbreviated version. We did have her in the ICU, just mostly to improve her nutritional status, to get her AFib with RVR under control. I did go to the operating room with CT surgery prior to our interventions where we did do a pericardial window. We sampled the fluid. Fortunately, it did not grow out anything, and there was no concern for infection. From the vascular surgery standpoint, our solution was to do a left carotid subclavian bypass. We then coiled the left subclavian to prevent future type 2 endo leaks, and finally did a thoracic endograft repair with a Terumo graft with a Knickerbocker technique to address her false lumen. These are just some of the angiogram pictures. The one on the right shows the patent carotid subclavian bypass and then the coil embolization. We did do these procedures 2 separate days compared to the TAVR. And then here is her TAVR repair after the Knickerbocker.
Can you explain that to the non-surgeon in the room?
The Knickerbocker technique? Yes, sir. The Knickerbocker technique is one way that has been described in the vascular surgery literature to address false lumen occlusion. So it's when you actually size your endograft to the true lumen diameter, and then you use balloon angioplasty to basically extend your graft to the true lumen, to the entire lumen of the aorta, and you do that in mid-graft. So you're sizing it to the entire diameter as opposed to just the true lumen. So key stages for this, I think, one reason that I really enjoy vascular surgery is we were able to do a hybrid approach and a multi-stage approach to a challenging thoracic aortic pathology. I think the big thing with this case was also just having a lot of patience. Like I said, when she arrived, she was very deconditioned, and really just taking the time to do what was best for the patient. And then the Knickerbocker technique for false lumen occlusion. I unfortunately don't have a follow-up scan for her. She elected to follow up with her surgeon. That was a little bit further away from Dallas, but she is doing well from a clinical perspective.
This paper's open. Any questions?
Great case. Sorry, this button is annoying. Question, can you tell us the distal extent of your TAVR graft? Because, the dissection went all the way into the visceral vessels and into the iliacs, but it doesn't sound like you covered, you must have landed this in the thoracic aorta.
Yes.
And then the Knickerbocker, did you embolize the false lumen also?
No. So our landing zone was a couple of centimeters proximal to the celiac. Her visceral segment, if you look back on the scan, fortunately did not meet any size criteria. She didn't have any evidence of visceral malperfusion or anything like that. And we only did the Knickerbocker technique. We did not use any embolization for the false lumen.
Yeah, because oftentimes if you treat the proximal, especially for the acute dissection, the flap will fall right over, and then you just have to surveil the distal part. So it's a great case.
Yeah. Our hope is, hopefully she will have some positive aortic remodeling, and her residual dissection will either heal or not progress to where she might need.
And did you IVUS? Did
Yes,
you see the
yes.
flap go over with the IVUS, which is always kind of rewarding because in the beginning it's always like a huge flap, and then once you fix the proximal, the flap goes right over.
Yes, yeah, we use IVUS a lot.
Isn't that kind of the importance of surveillance, is that with fenestration, you still have false luminal flow, right? You're at least supposed to. And so even though you clamp proximally, you may still have growth distally, so there's still a real need for surveillance here. Is there, I guess my question is, I didn't get a chance to look at it, but do all the true lumens come off of all the other arterial conduits come off the true lumen going into your abdomen?
I believe in this case, I think maybe her left renal came off of the false lumen, but I believe everything else came off.
And so she didn't have renal insufficiency or hypertension as a risk? Okay. There's a couple companies that are now looking at sealing the dissection planes with matrix rather than stent grafts, which is really kind of fascinating to me because the healing process, which you're describing by occlusion, tends to lend itself towards healing. And so they're trying to promote that with a matrix deposition, which in the ascending is really kind of the last, zone zero closure, which is kind of a cool thing.
Great case. Can you please explain the coiling, how the coiling was done? Because it's beautifully coiled, especially considering a lot of branches coming off. Did you go femoral or radial?
So we did brachial access for this. And like I said, we did this the day before we did the TAVR. And we were able to coil embolize, but we usually go from the brachial.
Did you consider coiling after you did the TAVR? Because then you could coil right up to the graft, right? You don't have to worry about ending up in the aorta. So sometimes we'll do that. Either you ligate it at the time of the bypass, which can be kind of treacherous because that proximal subclavian is kind of far away, which is always kind of ugly. Or if you're going to do it in 2 stages, you could coil it or embolize it after you put your graft in, and then you go right up to the graft.
I think we discussed it. I think we took her the next day.
Any other question or comment? Great job. Thank you. All right. Next is Dr. Zaid Aboud.
Okay, good morning, everybody. My name is Zaid Aboud, fellow at Aurora St. Luke's in Milwaukee. I'm honored to be here today to present our case about advanced endovascular technique in complex renal artery stenosis. Disclaimer, I was not operator, my attending were. is the...
Is that supposed to qualify as a complication, or is I wish I was involved?
I wish.
As someone who knows the operators, it's a fair disclosure.
Okay, is the green?
Green, big green.
Oh, okay, sorry. And as a follow, of course, I do not have any disclosures. Our case is 67-year-old male with a history of CAD, PAD, and hyperlipidemia, presented with refractory hypertension and worsening AKI a couple months after his EVAR procedure. Pertinent history, CAD with PCI to RCA mid-lat 2019. Similar year, he also had right external iliac artery and SFA intervention. And 2 months ago, he had alto EVAR placement for his fusiform 4.4 AAA. So at the time of follow-up in the clinic, his creatinine was roughly 1.4 from baseline of 0.8. CTA shows severe left renal artery stenosis with moderate right renal stenosis, which worse compared to his prior CTAs for his AAA follow-up. The renal artery angiogram showing nearly 1995 stenosis of the left renal artery. The right one is about 50, not shown here. So the clinical challenge is how to manage heavily calcified osteal lesion near the polymer ring of the alto EVAR. And this is the still picture of the alto device and the ring near the occlusion. So we brought the patient in, multi-purpose guide and 014 exchange whisper wire were used to engage left renal artery, sequential dilatation with initially 1.5, then up to 2.5 millim compliant. Coronary balloons were used, but unfortunately with poor results, inability to cross 3 or even 2 millim NC balloon, despite using guideliner and the stiff 014 wire with body wire technique. So the procedure abandoned with the plan to bring the patient again for a second attempt, and this is the final result, which is basically the same stenosis. So 2 weeks later, we brought the patient in. This time we used 7 French sheath via left brachial artery for better support. And unfortunately, we're still unable to cross the lesion with 2 millim NC balloon despite using the guideliner. So we consider atherectomy devices like rota and laser, but these devices were not recommended when we asked the companies because using them in the ring area might compromise the alto seal. So what we did, we used the 1.5 balloon that we previously, in the first attempt, we were able to cross the lesion with. And we inflated at 14 ATM distal to the lesion and used it as an anchor. After that, we were able to successfully cross the lesion with initially 2.5, then ultimately 5 millim NC balloon, which modified the lesion and enable us to deploy a 6x18 millim Herculink stent with very good results. This is the stent, then deploying it, and this is the final result. Creatinine improved in the follow-up visit, and blood pressure normalized. So key learning is highlighting the use of the balloon anchoring technique to facilitate renal angioplasty in balloon uncrossable, heavily calcified renal artery stenosis, especially in the EVAR ring. Overcoming challenging cases of complex renal artery stenosis on adaptability in endovascular procedures. Thank you.
So I'm going to steal Dr. Lee's question. Why did you not IVUS? I don't see IVUS anywhere in the films.
Yeah, I think the operator didn't didn't use it.
So the question for this is IVUS is extremely important. This is more likely than not is a graft-induced stenosis. The graft shifted or when they deployed it. But if you IVUS, you can tell what's going on. And the other question, if it's calcification that's causing you a problem, we've used shockwave or cutting balloon in this situation. Have you guys considered shockwave or cutting balloon in this case?
So when we asked the representative, they really recommend against any of these advices because of the polymer ring, just to not compromise the seal. So we didn't want to risk the everything and yeah.
That stent graft, it works very well, but the conformability is gone in now 17 or 15 minutes, right? So for you to cut into it, there's this big risk of anaphylaxis. People are allergic to whatever they make this polymer out of. So I guess exposing that would be a challenge. This is riding high, and that's what created this. So did you run, again, back to the IVUS question. I'm not a big IVUS dude, but I think the IVUS question becomes critical because if this is all the polymer sitting high, you have to set your stent into the aorta a little bit. Do you know where you were to the PTFE and the polymer ring? Because otherwise you have to telescope, right? I mean, that would be the alternative way.
Yeah, we see this, we do see this with other grafts. I actually don't use this graft, but you can see this with any of the EVAR grafts if the fabric is encroaching on the renal artery orifice. But then, did you consider using a covered stent, like a VBX? Because clearly this is not calcium or atherosclerosis or whatnot. This is like the polymer of the graft sticking up into, or fabric. So why not use like a VBX or something? Then you can really aggressively balloon it with the possibility of rupturing the origin of the renal, which can happen when you do this, but you're already covered.
Yeah, I'm not very sure, but they decided to go with this route, and they were successful. So
yeah, so I think the misconception about the VBX, I think first of all, I don't think you need to go brachial or seven French or any of this stuff. I think this is a case could have done radial, right radial, and you can get your Terumo 85 sheath, and you have all the support you need, and you get your guide and everything else. That's the way. And then you can get it. You can get the new VBX that can go through 6 French. You can get 6 or 7 millimeter through 6 French. I think it's a challenging case. I think the most important point of this case is what Dr. Garcia has said. You need to recognize the cause of the problem, and every cause is different. If it's atherosclerotic disease, what you did, I think, is great. If it's a polymer, what's going to happen with that stent? This stent will close. Yeah. Either instant restenosis or thrombosis, and so you have. What's the surveillance on this patient? How are we going to keep an eye on it?
Yeah, we closely follow him, just like a follow-up visit and CTA, and he was like, that's been a year ago, and he was like doing well. And initially we used the radial for the first attempt with 6 French, but we thought the second attempt probably, if it is like larger sheet, maybe have better support, but we were unable.
Yeah. Can I ask a dumb question from the cardiologist perspective? Because I'm not a surgeon, so you can help me out with this typo. But did anybody else on the surgical group see 4.4 centimeters as the primary modus of operandi for excluding this aneurysm?
Maybe it was symptomatic.
Was it 4.4 really, or was it 5.4?
Yeah, it's 4.4, but it's increased rapidly. It's more than 1 centimeter with less than a year. So we use that. And the alto, we don't use it that much, but he had like a hostile neck, is like less than 10 millim. So there is no other route but this graft.
Yeah, it is very hard to manage if the proximal neck is a problem. The other thing you can consider, and I don't know if this would work, because it looks like the renal was angled pretty upward, is a steerable sheath, because sometimes that really helps in giving you, because what happens is like, when you're trying to push against this occluded renal, it like kicks back, but the steerable sheath actually works pretty well, and you can do that from the groin.
Okay. Thank you.
I have one question. Maybe it's a pretty dumb question. When you say balloon anchoring, what were you anchoring against? Were you trying to telescope your sheath and anchor through that with the balloon, or what was it actually?
So, and we used the balloon of a pilot wire, and then we introduced the second balloon that we open on the lesion with through whisper wire. Like we anchor it against the second balloon. It just like give us a support to manipulate the actual balloon across the lesion.
I mean, I think what we mean is like what we do in the coronary when you can't cross something and you just balloon with a smaller balloon.
But do you have a branch to anchor that to? Like, isn't the
Mother-daughter
same
thing.
ostium, you can't be anchoring that with the same ostium and trying to pass? Are you using it as second wire just right next to an inflated balloon? We use anchoring when there's a branch and to hold the sheath in place and stuff. But I was just confused where you're anchoring that to pass the second wire
So
across.
anchoring just distal to the lesion to give us support for this, like the body wire next to it, which we use for the NC balloon and escalating dilation.
Yeah. So before you resorted to the anchoring, were you just having a lot of difficulty when you were trying to pass the initial balloons that your guide and guideliner were getting disengaged?
Yeah, that's the initial problem that we have the first and second attempt. We were unable to pass NC balloons, like even like 2 mm, yeah. So we were unable, but after the anchoring is like there is no pushback, so they were able to advance it.
Before trying the body wire or trying an anchoring balloon, did you consider using a different guide that may have potentially given you more support?
So we used the stiff wire in the first one and the guideliner, but didn't really help.
I think it's important to recognize sometimes you actually need a mother-daughter system, similar to what Dr. Seifu mentioned, having a long sheath in addition to your guide, plus minus guide liner, right? So having that extra long sheath, the Terumo R2P, right up against the lesion could actually help prevent some of this.
So it becomes a triaxial system, which is what you're describing, and it's like a radial tire. It gives you extra support. All right, well, that's fantastic. We need to move on. We're running late.
Thank you so much.
Last up is going to be Mira Kapadia. Is that close enough? God bless you for saying that that was close enough. It's going to be an unusual case of honeycomb vasculature in the periphery using angioplasty to take the sting out of CLI. All right, I want to know the sting, yeah?
So my name is Mira. I'm a third-year internal medicine resident at the UT in Houston, and I'd like to say thank you to the interventional cardiology team for allowing me to rotate with them and seeing cool cases like this one. I have nothing to disclose. And so our patient's a 72-year-old lady who presented with bilateral lower extremity non-healing wounds. She was on the hospitalist service. They completed an ultrasound of her lower extremity, which demonstrated diminished flow and monophasic waveforms, and brought her a cardiology consult. Her pertinent medical history included her CVA as well as CKD4, and her medications are listed. Given her history of CKD, we went and did a diagnostic procedure starting from the right side, looking over to the left. This demonstrates the iliac artery, and we see this characteristic honeycomb-like structure, so convoluted lumen with multiple channels of the left external iliac artery, high takeoff of the internal iliac, a normal common femoral artery with collaterals coming from the internal iliac artery. And then similarly, in the popliteal artery, we see this characteristic honeycomb-like structure and stenosis. So what is this honeycomb-like structure? So it's a rare phenomena of multiple communicating channels divided by thin septa detected on IVUS or OCT. The pathophysiology may be due to recanalization of a thrombus generated secondary to plaque rupture, erosion, embolism, or vasculitis. In our case, we thought our patient was secondary to vasculitis given the location from fibromuscular dysplasia, thrombotic recanalization, chronic occlusion with bridging collaterals, woven artery disease, or a partially healed dissection. So the clinical challenge was due to the etiology being elusive, most cases focusing on the coronary vasculature as opposed to the peripheral vasculature, and no protocolization existing for intervention, though endovascular intervention shows promise of high success. And so for the first intervention, we went retrograde from using a 6 French system across the common femoral artery with a coronary wire, had a 2 millimeter predilation, and then we can see the IVUS here following it, which shows the lovely multiple lumens that we're seeing with the false lumens there.
And then second, we completed angioplasty with a chocolate cutting balloon, which improved flow, but there was a gradient of the aorta to the common femoral artery of about 25 millimeters of mercury, and so there were 2 stents placed for the patient with improvement in flow afterwards. And this is the post-procedural IVUS on the left side. Similarly, on the right popliteal artery, we took an anterograde. We approached it anterograde with the 6 French system as well. Several wires were tried. However, what ended up working for this one was a cyanum block. You can see this going down. Similarly see it there. And then the IVUS is demonstrated here for this one as well. And then finally for this one, we had difficulty with our wiring through the TP trunk specifically, so angioplasty was completed, and we were able to pass a Gladius Mongo wire prior to stent placement as well for this one. And it shows up pretty nice. There we go. And so for the resolution of the challenge, we were able to see improvement of the patient's claudication and limb ischemia. Similar case reports with honeycomb-like structure due to thrombotic recannulization coronary vessels has been seen, and the stent was able to compress down on the false lumens in a similar fashion to restore blood flow. Our leading diagnosis of this was FMD, given the location of this being in the lower extremity iliac artery, with other things on the differential being chronic thrombotic recannulization. And the key learnings for the operator was to illustrate how IVUS can be utilized to identify structures such as these, understand the differential diagnosis of a honeycomb-like structure on angiogram, and demonstrate the successful response of the peripheral honeycomb vasculature to angioplasty. These are my references. Thank you.
Great case. I think because of the honeycombing appears in the bifurcation points, I would assume this was more thrombotic. So I would do post workup like TE, atrial fibrillation, those kind of things. Just a suggestion.
Gotcha.
So this is, first of all, I would recommend that you write this case to a journal, because I think the IVUS is very unique and we don't see it very often. But if you think an FMD has been described in other areas, and usually the treatment for FMD is some kind of a balloon or a specialty balloon with the DCB, and avoiding stenting to figure out what's going on there. Have you guys thought about doing that, or just because it was an iliac, you decided to just decide with the stent?
I believe because it was the iliac, we decided on the stent for it. That's my attending, yeah.
Great job. So she was in the lab, and she's one of our residents. No, those are great thoughts, and I'm not sure it was FMD so much, just basically a bit at different levels.
Excellent. Was it 2 different procedures, because you had a right groin access first and then left groin access, or you just?
Yeah, they were staged.
Diagnostic, there was the left, and then it came back.
And was that a balloon expanded stent in the popliteal?
Yeah, that was a resolute. That was an honest resolute. Yeah. So what we did was, again, I knew I had the secure lumen into the sort of perineal. So we used a dual lumen. We used Sasuke and used the Gladius Mongo to get through and negotiate so how the wire kind of spiral through. Then we broke up the septae, and then we had to leave something in the popliteal because there was an extensive dissection there. So we used a.
So if it's FMD, did you look elsewhere for FMD?
I think for her, she was undergoing workup, but they didn't see any other evidence for her.
So, I mean, the most common would be renal, and then you can still get carotid, right? I mean, that's the number 2.
Yeah.
Coronaries as well, yeah. I haven't seen it in coronaries.
Yeah.
But we were supposed to do a renal denervation. One of our first cases a few few months ago when I started in Roslyn, and it was a 76-year-old with FMD. It was the source, and it's surprising it wasn't found before. If it is all FMD, as a thought, then particularly for the popliteal or the trifurcation area, why not just debulk it with like a rotational device, break up the septa, and then do your DCB down there as opposed to leaving a resolute? Because I think that, Achilles will, and UConn and Destiny tell you that it'll work. The question is, it's a relatively short lesion, right? And so I think you're going to win either way, but leaving nothing behind may be a reasonable option.
Absolutely. So I think one of the challenges is the size of the DCB. In the iliacs, we don't have a DCB.
No, I'm not talking about the iliac. I'm talking about the popliteal.
Yeah, and so the popliteal, we don't have a DCB small enough because they're not approved. And so this is a 3-5 on resolute, I think, that we use. And so the problem is, even if you were to use, say, a 4-0, like one of those overnight systems, I think the time would be longer. We would have done more. But I think that's a great thought. We just, I guess, use it smaller.
That's right.
But that was a great thought.
Either way works.
That's
Thank you.
Thank you.
Great case.
I have one comment, sorry.
Oh, I'm sorry, one comment.
Yeah.
Just importantly, Dr. Garcia mentioned a lot of vascular beds that one should screen when you diagnose a patient with either SCAD or FMD. But one of the most important things is actually to do intracranial imaging as well. So CTA of the intracranial space too. And then not a lot of data on how to treat FMD in the extremities, but certainly in the renal arteries, the preferred approach is actually just plain balloon angioplasty. And as you know, you size up on the balloon sequentially until you receive enough of a gradient decrease. So for example, in the renals, you would do a 3-0 balloon, a 4-0 balloon, and I oftentimes would do this over an FFR wire such that I can measure the gradient kind of post-FMD lesions. And you essentially try to reach a gradient as close to 1 as possible, but you have to be aware that these vessels are super fragile. They can dissect at the drop of a hat. So that's something to consider when you do interventions on these. And then lastly, trust me, I'm not a salesperson for Abbott, but the popliteal lesion could actually have benefited maybe from a the drug resorbable scaffold actually, so that it.
Again, I mean, we don't have a hospital, and she's older. I mean, again, but me personally, I think the short sort of balloon expandable stents do fairly well in this short segment. It's not a long segment. But I think I'm not as convinced that this is FMD, just given the multiple channels. I mean, that's not a classic. That's more of a maybe recanalized thrombus appearance for me. But it could be FMD. That was part of the differential.
Yes, speed is kind of interesting because you have to size it appropriately. That's where IVUS comes in. But again, I think that a debulk DCB works because then you can always restent, right? Or you can always stent. So, but listen, that was great. Thank you very much. Thank you to all the presenters. Thanks to all the presenters. These were great cases. Geez, I can't remember when I was a fellow to have nice cases like that. So, and bringing up syphilis in a context of an intervention, that just brings back nightmares. So thank you. We have to do this old school, so we have to meet up here, and you guys can take a break. We have, I guess, 20 minutes now. Josh or somebody could tell me if that's true. And then we'll come up with the top 2. We'll give you our numbers or our winner in a second.
You won't do that. You'll give me that number. It's a secret.
Okay. Oh, I get to give it to you.
They're going to give it to me, and I'm going to keep it a secret till later today.